I want to know everything about her. Her physiology, what she looks like, her history, her aches and pains as she works with me through the pregnancy. The other thing I wanted to mention that, you know, that's why continuity of care is so important. We know the woman when she comes in labor. We're confident that she has the right nutrition, her baby is in the right position. We can have and giving her that confidence of knowing that she is on the right track. She is ready to bloom, as it were. So that's what we know. Then what we see, what are we looking at when this woman comes into our presence? What is her presentation? Is she well dressed? Is she poorly dressed? Is she very thin? Is she very large? Is she anxious? Is she walking around? How does she behave? Is she sleepy? Is she got a soft jaw? Is her jaw open or is it closed? These are all things which will give you information about the mother, about where she's at. Sometimes I've had mums come in labor, and I'm thinking of one mum. You know, when I'm talking to you, I see the pictures of these women in my mind's eye, and it's really wonderful to share the stories. And she came in and she was very tight, beautifully dressed, came in with a very lovely, attentive husband. And she said she's getting contractions regularly and she is in labor. And I had to reassure her somehow that things were fine. She was very anxious. And so when I had examined her, and I did do an examination, I said to her, look, it's still very early and you're welcome to hang around in the hospital, but I suggest you go home. And I showed her how to breathe, and I drew the husband aside and I said, you know, your wife is doing so well and she'll do even better when she's relaxed. So I suggest you go home and do some loving. And when things get stronger and she's a little bit more in pain and she's not quite as relaxed, then you bring her back. And it was so sweet because she came back about 6 hours later and he said, Sister Little, I told you, I did everything you said. She was in strong labor and gave birth a few hours later. And then also look at the abdomen. Look at the color of her skin. Look at the color of her abdomen. Is she hydrated? Is her skin loose or hydrated? Is she eating? Is she vomiting? And how is she breathing? Sometimes a mum comes calls me, and she's in, especially the first time mums in very early labor, and they're breathing up here during the contraction. And what does that do? That causes hyperventilation. And what does hyperventilation do? It concentrates all the oxygen and carbon dioxide around the center of the body. The fingers start tingling and the mother feels faint. And it's not a very good idea because it means that the oxygen that she is inhaling is not really getting to the baby. So when you are dealing with a mum who's very anxious and she's clearly not in active labor, you sit her down and you say, look, this is how things are. Labor can take a very long time. Time disappears when you're in labor. Let me show you how to breathe. And I show her how to breathe. And the breathing technique is very, very simple, particularly in early labor. She inhales and she holds the breath. And she lets it go down to the alveoli, right at the bottom of the lungs. And she keeps holding that breath for a few seconds more. And then when she blows out the breath, she purses her lips. And breathes out that last little bit of air. And then takes another deep breath. And holds it. 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 And then she blows it out. So you can teach her to breathe correctly without touching her. And that breath will give her a huge amount of relief. When the muscles of the uterus contract, they squeeze out all of the oxygen from the fibers in the muscle. And that causes an increase in the sensation of pain for the mother. So when she's breathing correctly, the sensation of pain is lessened and she can relax during the contraction as well as in between the contraction. In fact, many, many mothers, when I've shown them this breathing technique, they sleep in between the contractions during early labor. And that is exactly what they need to do. They need to sleep. They need to get into that very slow brainwave pattern where the brain starts to switch off and the body starts to relax. That is a fantastic state for early labor. What is her environment? What do you see if you're going to a home birth? Some home births I've arrived and the whole tribe is with her. The husband, the mother, the aunties, the uncles, the neighbors, the grandmother, both grandmothers, and it puts this mother under pressure. There's lots and lots of distractions. Everybody's wanting her to do something. They all want the baby to drop right there because they all want to be part of the birth. And unfortunately, it impedes the mother's labor. So I can be quite a strict midwife, just as much as I can be loving, and I request everyone to leave in a very calm way, and I just explain to them why. And once the people have left and the house is quiet, I take the mother and put her into that breathing rhythm, and she calms down and the labor can progress. One of the things that I've learned about over the years has been the purple line. Have you all heard of the purple line? The purple line is a line that supposedly creeps up between the buttocks of the pelvis. And when the mother is coming to the end of her labor, the purple line extends up towards the sacrum. And when you observe a pregnant woman in labor, her whole labial area and pubic area, right from the front all the way to the back, changes color. The pigmentation goes darker, and that happens from the front to the back. Obviously, I don't generally ask women to display themselves to me in that way. So what I do is I will offer to help the mother go to the bathroom and empty her bladder, and while she's undressing and dressing, I take a sneak peek at the back in a very unobtrusive way and get a good visual of whether the purple line is beginning to ascend towards the sacrum or whether it's still down, well down between the buttocks, the folds of the buttocks. And that gives me an idea in synchronicity with all the other signs that I've been looking at, of how far is the mother is in labor. Maybe she's halfway, maybe she's still very early, I can't see any purple, or maybe she is coming towards the end of her labor and I can begin to see this pigmentation rise up to the sacrum. And different women have different pigmentation in their skin, so it's different for every woman. Some women will have a very faint change in coloration, and other women will have a very dark change in coloration. So it's just a way to reassure yourself that you are on the right track and that labor is progressing. So that we've done two ways in which we can glean information from the mothers: what we know and what we see. The next sensation that I use to gain information from the mother is what I hear. So how does the mother's voice sound to you when she speaks to you on the phone and tells you she's in labor, or when you go around to her house and listen to her telling you her fears and her story and what she thinks and how many contractions she's been having and how strong they feel and where the pain is? You listen to her voice, you check the tone of her voice, you check the pitch of her voice, the speed at which she speaks. Is her brain still on full speed functioning? And if it is, she's not yet in active labor. We can't do, you know, labor is one of those things that we can't do two things at once. We actually need to get out of our brains and into our bodies. And in order to do that, our brain has to shut down. We have to sink into a very primal way of being. And talking at a birth disturbs the mother. So your job as the midwife or as the birth attendant is to listen. And if the mother's still got lots of words to tell you, she's still in early labor. She hasn't yet progressed to that stronger labor where the hormones are busy shutting down her intellectual function. Sometimes women are very introverted and they don't talk much. And I've had the pleasure of being at many of those births where the women just go into themselves and they just sink into this very, very quiet, silent state. And I don't say a word either because that is where she needs to be. Is the mother complaining a lot? Likely, if she's verbally complaining, she's still in early labor. Generally, as labor progresses, a mother stops complaining and starts making utterances. I don't know if you can get the distinction there. Shouting, moaning, screaming, groaning, grunting, breathing. Those are the utterances that a woman makes when her labor is progressing. And so you're gauging, but you don't have to touch her. You haven't yet touched this woman. You've picked up an awful lot of information from what you know about her, from what you see, your visuals, what you observe, her behavior. And you're picking up information now about how she sounds. Do the sounds start low and work their way up to a crescendo, or are they vomiting sounds? Some women vomit all the way through their labor. Does she need to swallow? Are you going to offer her some water? And you don't have to speak when you offer her water. You can just offer her a glass of water. If she doesn't want it, she'll ignore you. If she wants it, she'll take it. And what you're also observing in the sounds is a kind of rhythm. I don't know if you've watched that clip. There's a wonderful clip on YouTube about rhythm in Africa. And the producer has put together all these African sounds and the sounds of an African settlement, living and eating and pounding their wheat and cutting the thatch grass for their roofs and lighting the fire, and all the sounds that go together to make this symphony of our lives. And women in labor have rhythm when the labor becomes active. And these days that is suggested, or it's been put out by NICE and other organizations from different countries that are putting out guidelines for when a woman is in active labor. And they're saying now that a woman is possibly only in active labor from about 6 centimeters. I actually personally don't like to pass judgment on that, because some women can get to 8 centimeters and be very breezy and not at all perturbed by pain or anxious or worried, and then suddenly in half an hour they'll give birth. So when was she in active labor? Was she in active labor up till 6 centimeters, or was she in active labor or was she not in labor, in real labor, until she was 9 centimeters, after which she gave birth very quickly? So it varies from woman to woman. That's why it's so important to know the woman you're working with. So we've done what you know, we've done what you see, your visuals, we've done what you hear, your auditory sense. And now we're going to talk about what you feel, what you as the midwife feel. Now, I'm a very feeling person. I wear my emotions on my sleeve. I can't hide them. In fact, if you look at my face, you will see what I'm feeling. I can't hide if I'm happy, and I can't hide it if I'm sad. And so what happened to me in my experiences with women is that after a while, I started to experience what felt to me like labor in my body. So if the woman was nauseous, I felt nauseous. If the woman was vomiting, I didn't vomit, but I felt like it. If the woman was in pain and uncomfortable, I would be afraid. So where do I feel my fear? In my solar plexus. And that was quite confusing in the beginning, because I would think to myself, well, am I afraid for this baby? And then I would run through in my head, okay, is the position of the baby good? Is the baby well engaged? Is the baby descending? Yes, it looks like it. Is the mom progressing? Yes, the purple line was halfway up her sacral area when I last checked, and she is making the right kinds of noises, and I can see the baby moving in the abdomen, and the mother tells me that the baby is moving in between surges. Then I know that the fear is not my fear. Actually, everything's fine. It could be the mother's fear. So what's needed at that point? Perhaps you just reflect to the mother and say in a very gentle voice, what are you feeling right now? And she will tell you what she's feeling. And if she's in active labor, she's not going to be able to tell you what she's feeling, but she may be feeling it anyway. Another thing that I've experienced in labor is anger. And this is quite an interesting story. This particular mother was born by cesarean section herself. And so her mother gave birth to her by cesarean section, but And I think her grandmother also gave birth by cesarean section, but her great-grandmother gave birth normally. And other than that basic information that it was an emergency and she didn't quite know all the reasons, but that's what happened, and she was really keen to give birth vaginally herself. So she was in the bath for some of the active labor, and I was sitting quietly next to the bath, and her partner was on the other side of the bath holding her hand. And this mother was really making utterances, strong utterances. And I knew that the baby was, everything about the baby felt right. The baby was in the right position. Everything was normal. She'd progressed. She was making all the right sounds. And I just encouraged her to breathe very gently. But I felt this anger also down in my stomach, like not my solar plexus, but a little bit lower down. And I was just watching her quietly and thinking to myself, okay, whose anger is this? Because I'm not angry. I know what's going on, and I'm waiting. So is this her anger or my anger? And then I thought to myself, okay, so this is her anger. She's really angry. And I think she's really, really angry with me. And what am I going to do about it? Am I going to sit with it? Am I going to reflect? Am I going to tell her, reflect and say something about the anger in the room? What am I going to do? And then I thought to myself, but hang on a minute, I'm a big girl. I can deal with her anger. It's not going to hurt me. I can hold it for a bit. It's okay. And I just stayed very, very calm and worked with the sensation of anger in my bowel and with what we call in psychology terms, transference and countertransference. So what happens in transference is that the mother or the person or the woman, and possibly also either or the husband or the birth companion, feels something, and they don't want to feel that thing right there, and so they displace it onto the safe person in the room. And I was the safe person in the room, and so I got that transference, and then I had to examine the countertransference. So was it my anger or was it her anger? Was I really angry with her? No, I was patient with her. I wasn't going to go anywhere. I didn't have any other commitments. I was completely with this woman, and we sat. The baby was born eventually, and everything was healthy and normal, and she was extremely grateful. And then we needed to debrief. We didn't debrief straight away, because straight away you're overtaken with this baby that you've given birth to, and your focus is on all those sensations and the sensations in your body and the relief that everything is over. So the next day we did some debriefing, and what came out in the debriefing was this. She said to me that she was angry with me because she knew that somewhere in my bag of tricks I had a scalpel, and I was going to save her with that scalpel, and I was going to pull the baby out and save her from the pain of this birth. And I said to her, what was that? And she said, you know, that's what happened in my birth. She said it was a horrendous emergency. My mom had been in labor for hours and hours and hours. And as a baby, I knew that doctor had a scalpel, and he saved my life with that scalpel. And that was just so fascinating to me. So the capacity that we have as midwives to hold the space is massive. It's a massive responsibility. It's a massive undertaking. And those of us, look, we all do it in different ways. And there are some midwives who are not as feeling as I am in my body and who experience as much transference as I do. And that's fine. But it's also a protective mechanism. So I've also had experiences of transference from the baby. And that, if I can interpret it correctly, also puts me in a good position to assist the mother and the baby and myself. That's why self-care for the midwife is so important. And when we are not looking after ourselves and not taking care of our bodies and not sleeping enough and not asking for help when we need it and not making sure that we get the help when we need it, that is when we make mistakes by omission or commission. And those mistakes can cost us dearly. So it's really, really important to look after ourselves as much as we import or encourage the mother to look after herself. So we need to set that example. And I think as I've got older, I've learned that in some very, very strong lessons over the last 7 years. The last sensory, thanks Cathy, 45 minutes. The last sensory sensation that we're going to work with is smell. What do you smell? How does the mother smell when you meet her? Quite often when I go into a mother's home, it'll be cooking. So I've been into mother's homes where there's been a grandmother cooking away. I've had all sorts of wonderful meals in parents' homes, families' homes, and cooking is a very calming activity, as is knitting. Cooking helps the grandmother calm her nerves, and she's able to give birth in a way as her daughter is giving birth to her food, her nourishment. And so what does that smell like? And that's just a wonderful, enriching sensation. Then what does the mother smell like? Is she acidotic? Is she ketotic? Does she smell sweet? Does she smell sour? Has she been eating? Has she been vomiting? You can learn those things from the sensation of smell. And then, of course, some people must think I'm a very weird midwife, because when a mother takes off the pad, I want it. And the first thing I do is smell it. And then I have to explain. It's really important to smell. That if a discharge has a clean smell or an offensive smell, that gives you information about the state of this mother's health. Does the amniotic fluid smell? Does the pad smell of amniotic fluid? Can you smell the amniotic fluid when she is discharging amniotic fluid? And what does it smell like? And then the most significant smell is, of course, two things: the smell of poo and the smell of the baby coming. And there's a slight distinction. So am I okay to continue, Cathy? Thank you. So I remember one mum, we were in a birth unit at that time, and she said, "Oh, I've got to go to the toilet," and I could smell the smell. And I thought, oh, no worries. I think this baby, she's almost ready to birth this baby. And I had some linen savers, and wherever she was crouching, I placed some linen savers under her, and she would deposit an ice cream cone of poo, and I would quickly wrap it up and pop it in the bin. And every time she crouched again, I thought, that's the one, that's when the baby's going to come. And the baby didn't come. It took about 5 or 6 piles before the baby started coming. So by the time I'd wrapped up 6 little piles and deposited them in the bin, I needed to to set up my aromatherapy oil burner with some strong lavender and clary sage to kind of sanitize the room. And then the baby came. And the smell of the baby coming is slightly different from the smell of the poo. And linen savers, Inco sheet, yeah, incontinent sheet. So it's got sort of a cotton woolly layer on the upside and plastic underneath. And yes, I smell and the behavior of the mother. Because a mother, usually when she wants to give birth, if she's upright in the active part of her labor, most of my clients will want to be upright and will usually want to go to the bathroom, because what they feel like is that they want to poo. And the problem with me in this case is transference. I've also almost missed a birth because I have the same sensation. And so I trot off to the loo and the woman's almost giving birth. And that's a little bit too much of a confluence. But that sensation of needing to poo, that is often a sign to me that the baby is coming as well, and that I need to just stand gently in the background and have my little pile of incontinent sheets, linen savers, my towels, and my surgical kit ready. So you need to have your resuscitator ready, you need to have your gloves ready, you need to have washed your hands, and you need to have also, by that time of the labor, asked the mother to make sure that her hands are clean. Okay, because the ideal is for the mother to give birth. And the mother she can catch her baby. Sometimes the fathers catch the baby, although I prefer the mothers to catch the baby, but sometimes they're not up to it. Sometimes I have to catch the baby if the mothers are, in my practice, they give birth a lot in a sort of a standing, semi-standing position, which is a really, really good position for not tearing of the perineum. I don't support the perineum. I encourage the mother to adopt a position that doesn't put undue stress on the perineum. I never coach a mother, usually never. Occasionally, I will encourage her to bear down, but usually I will not actually say anything while a mother is bearing down, because she needs to get into her rhythm. She needs to follow her body at that time. She needs to bear down when it's comfortable for her and how much it's comfortable for her. And that will bring the head down slowly. You know, I learned something really important from the midwives before the hospital became more medicalized, when I used to work at Mowbray Maternity Hospital. And the older midwives, the mothers were fully dilated, but the head was still high. And they used to say to those mothers, come, you're not ready to birth this baby yet. Have a sleep. Let's rest. And they'd put the mothers on the side with a cushion between their legs, and they'd say, now you just breathe your way through these pains. The baby's coming, it's all going to be okay. And sometimes they would lie there resting for 6 hours. Okay, they were fully dilated, but the head was descending. There was no stress. They had monitors on that were regularly checked. They were left alone to let this baby come down the birth canal by itself and at its own pace, which is much healthier than when you are squeezing and holding and squeezing and pushing all your breath out. Midwife uses 5 senses. That's it. That's it. So when the mother gives birth, when she actually gives birth to the baby, quite often she's not ready at the moment of birth to take the baby herself. So what I do in my practice is I will possibly catch the baby, bring the mother into a position where we've made a little bed, a little pack of towels on the floor, and bring her down so that she can lean against the wall and sit on this pack of towels and some linen savers. And I put the baby in between her legs on the floor, on the linen savers. By this time, I've got the baby in a towel, and we dry the baby gently and wipe the baby's face, and I cover the baby and I leave the baby between her legs so that she can pause and gather herself. It's a big event that's just taken place, and her body might be in shock, and she can't put her attention just yet on the baby. So sometimes the baby will lie there for 5 to 10 minutes before the mother picks the baby up towards her chest. And in that time, the placenta is still attached. The baby's in a wonderful position to still be infused with the blood from the placenta via the still pulsing cord. And the baby gets the full quota of blood, which then helps to inflate the alveoli, and the baby's breathing. So the pause. I'm going to wind up now. The conclusion. There's so many things that we could talk about, but I'll leave that for the question and answer. We need to teach the mothers. We need to empower the mothers. We need to show them what they need to know so that they can give birth. We need to give them confidence in their bodies. We need to explain that the vaginal tissues and the labial tissues are created like that so that they can stretch. And they can stretch up to 10 times the normal size. We need to talk about these things. We need to desensitize a mother to trauma by allowing her to share her trauma with us during the pregnancy and also sometimes during the birth, because the hormones are opening up all the systems in the body, and sometimes she needs to express that trauma. We need to be a presence as well as be present. We need to be fully present in the room, not distracted by things that are going on in our lives, by the clinic I've just had to cancel because I'm now with a mother in labor, by the appointment at the bank that I've got to make because I need to sort something out. I've got to leave those outside the door and be fully present and be a presence. Because that, the knowledge that you have, the confidence that you have in her physiology, the knowledge of your own body and your own sensations, those are the things that will give you presence. And when you have presence at a birth, you make the mother feel secure. She knows that you're there. She knows that you're capable. You don't need to do anything to show her that you're capable. She knows that you are on her side and that you're watching, and that if you need to step in, if progress doesn't go as it should, and there are too many hours between the hours when there are no signs of progress, you're there and you can give her feedback and you can discuss what it is that she would like to do. So that it's the mother who's giving birth. And what we've been taught in medical school and in midwifery school and in nursing schools is that we fix things. And sometimes we can't fix things. So we have to know the difference. And the more we are a presence at a birth, the more we're going to be able to sit on our hands, the more confidence we're going to have with women, and the more confidence they will have because they are not picking up on our fear. You see, that's the countertransference. And if you're a very anxious midwife, maybe your cesarean rate is going to be a little higher than a midwife who is less anxious. There's no judgment in this. We all have to find the ways that we are comfortable to be with women, and that is what they ask of us. And then when we come away, we have to self-reflect. So we come away from a birth and we go through the birth notes and we say to ourselves, what did I learn? Who else birthed like this? Who was she like? Who was she different from? How was her birth unique? What can I learn from this woman? And that goes into your repertoire of knowledge so that next time, in 10 years' time, you meet a woman who's similar to the woman who gave birth with you 10 years ago, and you recognize the similarity and you say, ah, I have that repertoire of skills. I know what I can do if she needs help. And that's it, ladies. I'm going to end on that note. Thank you very, very much. It's been 1 hour. You've been very patient listening to me, all my ohs and ums and buts and so's. I will wean myself of using those crutches. Thank you. Thank you so much for joining me today. And I hope to share with you tomorrow for mothers and for doulas, how to actually give birth on your own or with someone who does nothing. Thank you so much. Bye-bye. So must I unmute? No, I'm not muted. Ha ha ha. Thanks, May Wu Wan. Lovely to have you with us.
Did you see the message from Debbie?
No.
Debbie's...
There we are. Where's Debbie? Thank you so much. Very informative and loved it. Do you have any questions?
Yeah, that was me.
May one to everyone. Thank you.
Cool.
Who
That was
else?
excellent, Marianne. Excellent.
Has Caleb left us?
Yes.
I think Caleb
yes.
left.
Yep. Cool.
Super. Thank you so much. And yes, happy midwifing.
It was fascinating. You're so wise, Marianne.
Yeah. Thank you, Cathy. Yeah, you know, sometimes I feel like I'm still a 20-year-old learning.
Do you want to just tell people about when the recording will go out and tomorrow's one?
Okay, so we'll send within 24 to 48 hours, we'll send a recording of the webinar, and I can also send out my PowerPoint notes